Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 300 of our pharmacotherapy series, which majors in acute coronary syndrome. The first question relates to patient PhD in part 299 of this pharmacotherapy series. Would PhD benefit from the addition of clopidogrel to his current drug regimen? Two studies have evaluated the potential role of in-hospital clopidogrel as an integral part of fibrinolytic therapy in patients with STEMI. The clopidogrel as adjunctive reperfusion therapy thrombolysis in myocardial infarction 28, abbreviated as Clarity-TIMI 28, evaluated patients with STEMI who received standard fibrinolytic therapy, aspirin, and unfractionated heparin, and were scheduled for angiography within 2 days. Patients received either clopidogrel, 300 mg loading dose, followed by 75 mg daily, or placebo within 10 minutes of fibrinolytic administration. Clopidogrel was continued up to and including the day of angiography and then stopped. The primary endpoint was the composite of an occluded infarction-related artery on pre-discharge angiography or death, or an myocardial infarction up to the start of coronary angiography. Compared with placebo, patients receiving clopidogrel demonstrated a 36% reduction in the primary endpoint with a p-value less than 0.001. By 30 days, the clopidogrel treatment group had a 20% reduction in cardiovascular death, recurrent myocardial infarction, or recurrent ischemia, with a p-value equal to 0.03. No difference in the rate of major bleeding was seen between groups. In a substudy of patients proceeding to non-emergent percutaneous coronary intervention after fibrinolytic therapy, patients receiving pretreatment with clopidogrel demonstrated a 66% reduction in 30-day mortality compared with those receiving placebo with a p-value equal to 0.034. The clopidogrel and metoprolol in myocardial infarction trial, abbreviated as COMMIT, evaluated the effect of clopidogrel 75 mg daily with no loading dose, or placebo, in 45,852 patients presenting with STEMI. In the trial population, 93% had ST segment elevation or bundle branch block, 7% had ST segment depression, and 54% were treated with fibrinolytic therapy. The initial clopidogrel dose was given within 24 hours of symptom onset and continued until hospital discharge or up to 4 weeks in the hospital. Compared with placebo, clopidogrel was associated with a 9% reduction in death, reinfarction, or stroke, with a p-value equal to 0.002, and a 7% reduction in all-cause mortality, with a p-value equal to 0.03. No significant excess in bleeding was noted with clopidogrel, either overall or in patients who received concomitant fibrinolytic therapy or were older than 70 years. On the basis of these two studies, PhD should receive clopidogrel as an inpatient. The next question reads, what dose of clopidogrel should be considered? According to the 2013 ACC/AHA guidelines, clopidogrel should be added to aspirin in patients who undergo reperfusion with fibrinolytic therapy. A loading dose of clopidogrel 300 mg can be administered with fibrinolytic therapy followed by 75 mg per day for maintenance. The maintenance dose should be continued for 14 days and up to 1 year. The 1-year duration is extrapolated from experience with NSTEMI. There are no studies evaluating a 600 mg loading dose in patients with STEMI treated with fibrinolytics. Additionally, uncertainty exists about the safety of giving a loading dose of clopidogrel in adults 75 years of age and older, particularly when they receive a fibrinolytic. Therefore, in this population, a loading dose should be avoided. A single loading dose of 300 mg of clopidogrel should be given to patients less than 75 years of age who receive a fibrinolytic agent and are subsequently proceeding to percutaneous coronary intervention within 24 hours. If the patient received a fibrinolytic and then proceeds to percutaneous coronary intervention after 24 hours has lapsed, then a loading dose of 600 mg is preferred. For PhD, a loading dose of 300 mg of clopidogrel should be administered at the time of fibrinolytic administration followed by 75 mg per day for 14 days to 1 year. Because PhD has already received 325 mg of aspirin in the emergency department, he should continue 81 mg of daily aspirin indefinitely. The next question reads, what roles do the other anticoagulant and antiplatelet agents have in PhD's management? Data available with the newer P2Y12 inhibitors when used in the setting of fibrinolytic therapy are lacking. It would be prudent to avoid giving prasugrel and other potent P2Y12 antagonists no sooner than 24 hours after administration of a fibrinolytic. Coronary anatomy should be known to ensure the patient is not a candidate for CABG. The replacement of unfractionated heparin with a low molecular weight heparin, factor Xa inhibitor, or the addition of a glycoprotein 2b/3a inhibitor to fibrinolytic therapy has been evaluated in patients with STEMI. In the enoxaparin and thrombolysis reperfusion for acute myocardial infarction study 25, abbreviated as EXTRACT-TIMI 25, 20,506 patients with STEMI scheduled for fibrinolytic therapy were randomized to receive either enoxaparin or continuous infusion of unfractionated heparin for 48 hours. Enoxaparin was dosed according to age and renal function. Unfractionated heparin was dosed according to weight and adjusted to achieve an activated partial thromboplastin time 1.5 to 2 times control. The composite endpoint of death or non-fatal myocardial infarction through 30 days occurred in 12.0% in the unfractionated heparin group and 9.9% in the enoxaparin group, representing a 17% risk reduction, with a p-value less than 0.001. No difference was noted in mortality between the two groups. Major bleeding was higher in the enoxaparin group. The Organization for the Assessment of Strategies for Ischemic Syndromes, abbreviated as OSCEs, was a randomized, double-blind trial of 12,092 patients with STEMI assessing the effect of early initiation of fondaparinux with primary percutaneous coronary intervention and medical therapy. The study compared the effects of fondaparinux with two different control arms. Patients with confirmed STEMI were assigned into one of the two following strata. Stratum 1, no indication for unfractionated heparin, patients receiving streptokinase or those not receiving a thrombolytic agent were assigned to this stratum. Stratum 2, indication for unfractionated heparin, patients receiving all teplase, reteplase, or tenic teplase, and those undergoing primary percutaneous coronary intervention, were assigned to this stratum. Death or reinfarction at 30 days was significantly reduced in the fondaparinux group. However, fondaparinux did not benefit patients who were managed with primary percutaneous coronary intervention. Although the rates of death, myocardial infarction, and severe bleeds did not differ in these patients, there was a higher rate of catheter thrombosis with fondaparinux. The TIMI-14 trial demonstrated enhanced reperfusion (TIMI-3 flow) using reduced-dose tissue plasminogen activator combined with abciximab compared with full-dose tissue plasminogen activator alone. The GUSTO-5 trial compared standard-dose reteplase to half-dose reteplase plus full-dose abciximab in STEMI patients. The combination group had less reinfarction and recurrent ischemia, but more episodes of moderate and severe bleeding, especially in the elderly. Similar rates of enhanced reperfusion have also been observed with the combination of double bolus dose eptifibatide 180 and 90 micrograms per kilogram, 10 minutes apart with a 48-hour infusion 2 micrograms per kilogram per minute, plus half-dose tissue plasminogen activator dosed at 50 milligrams. The ASCENT-3 trial assessed 3 regimens. 1. Full-dose tenecteplase plus enoxaparin or 2. Full-dose tenecteplase plus unfractionated heparin or 3. Half-dose tenecteplase plus unfractionated heparin with a 12-hour infusion of abciximab. The addition of either abciximab or enoxaparin to tenecteplase reduced the composite endpoint of 30-day mortality, in-hospital reinfarction, or ischemia compared with unfractionated heparin. More major bleeding complications were seen with abciximab compared with unfractionated heparin. In a meta-analysis of 11 trials involving 27,115 STEMI patients who received adjunctive abciximab in addition to either percutaneous coronary intervention or fibrinolytic therapy, use of abciximab was associated with a significant reduction in 30-day, with a p-value equal to 0.047, and 1 to 6 month mortality, with a p-value equal to 0.01, in patients undergoing percutaneous coronary intervention but not in those receiving fibrinolytic therapy. Despite an improvement in patency rates, the combination of glycoprotein 2b/3a inhibitors with either full or half-dose fibrinolytic should be avoided if at all possible, especially in the elderly. Based on data from Extract TIMI-25 and OASIS-6, the ACC/AHA guidelines allow for substitution of unfractionated heparin with either enoxaparin or fondaparinux. However, whereas fondaparinux appeared to be superior to control therapy in the OASIS-6 trial, relative benefit compared with placebo and unfractionated heparin separately cannot be reliably determined. If enoxaparin or fondaparinux are selected, anticoagulation should be continued for the duration of the hospitalization, up to 8 days or until revascularization. For PhD, enoxaparin would be the more appropriate choice, however, he will have a higher risk for bleeding and need to be monitored closely. Because PhD is not undergoing percutaneous coronary intervention, the bleeding risks outweigh any benefit from the addition of a glycoprotein 2b/3a at this time. The next question reads, how can you monitor for successful reperfusion in PhD after he has received fibrinolytic therapy? It is important to determine whether thrombolysis has been successful because the prognosis of the patient is related to the presence or absence of an open infarction-related artery. If fibrinolytic therapy fails to open the infarction-related artery, then the patient may benefit from percutaneous coronary intervention or a CABG. Although coronary angiography has been the standard for determining the success of reperfusion, this procedure is expensive and may be misleading, as some studies have suggested that microvascular perfusion may be impaired even when TIMI grade 3 flow has been achieved. A simple and readily available technique is evaluation of ECG ST segment resolution. A resolution of more than 50% of the ST segment elevation at 60 to 90 minutes after the initiation of fibrinolytic therapy is a good indicator of improved myocardial perfusion. Relief of symptoms, maintenance or restoration of hemodynamic or electrical stability or both, and a reduction of greater than 70% in the initial ST segment elevation are all suggestive of adequate reperfusion. PhD should undergo a 12-lead ECG to evaluate reperfusion. The next question reads, PhD continues to have chest pain. Should the thrombolytic be re-administered? Let's discuss re-administration of thrombolytic agents. Reocclusion of the infarction-related artery after initial successful thrombolysis is a major setback. If reocclusion occurs, mechanical intervention, e.g., percutaneous coronary intervention, is often attempted. Several studies have evaluated whether to re-administer the fibrinolytic or refer the patient for percutaneous coronary intervention. In a meta-analysis of 8 trials of patients with STEMI who failed fibrinolytic therapy, those receiving rescue percutaneous coronary intervention showed no significant reduction in all-cause mortality, but had a 27% risk reduction in heart failure, with a p-value equal to 0.05, and 42% reduction in reinfarction, with a p-value equal to 0.04, when compared with standard medical therapy. Repeat fibrinolytic therapy was not associated with significant improvements in all-cause mortality or reinfarction. Both treatment strategies demonstrated a significant increase in minor bleeding, but percutaneous coronary intervention was associated with an increase in stroke. The Rapid Early Action for Coronary Treatment, abbreviated as REACT study, found that patients who received rescue percutaneous coronary intervention compared to repeat fibrinolytic or conservative care had a significantly lower composite of death, reinfarction, stroke, or severe heart failure at 6 months, event-free survival rate 84.6% versus 70.1% versus 68.7%, respectively, with a p-value equal to 0.004. The ACC/AHA guidelines recommend that patients who have failed fibrinolytic therapy undergo catheterization with appropriate antithrombotic therapy if possible. Patients best suited for catheterization consist of those with high-risk features such as cardiogenic shock, significant hypotension, severe heart failure, or ECG evidence of an extensive area of myocardial jeopardy. In the case of PhD, a repeat infusion with tissue plasminogen activator would probably be safe, but it may not be effective. If a percutaneous coronary intervention-capable institution exists, PhD should be transferred for an invasive strategy at this time. The next question reads, if PhD had been 85 years of age, should he have still received fibrinolytic therapy? Some of the early trials with fibrinolytic therapy excluded the elderly. Although the elderly may have a higher prevalence of relative contraindications such as severe hypertension or history of stroke at presentation, they also have a higher incidence of mortality after an acute myocardial infarction. The 30-day mortality rate after an acute myocardial infarction is 19.6% for patients between 75 and 84 years of age and 30.3% for those who are 85 years of age and older. In the ICES-2 trial, the greatest reduction in mortality occurred in the elderly subgroup. There are no controlled trials in which fibrinolytic therapy has increased mortality in the elderly. However, in a high-risk cohort of elderly female patients older than 75 years, below 67 kilograms, the ASCENT investigators demonstrated that tenecteplase was associated with lower rates of major bleeding and intracerebral hemorrhage compared to tissue plasminogen activator. Another potential strategy to reduce intracranial hemorrhage risk is a reduced dose of fibrinolytic. The strategic reperfusion early after myocardial infarction, abbreviated as STREAM trial, evaluated pre-hospital fibrinolytic therapy and reduced the dose of tenecteplase by 50% in patients equal to or older than 75 years of age. The intracranial hemorrhage rate was reduced to 0.5% and coronary patency rates were similar when compared to patients younger than 75 years of age who received full-dose tenecteplase. It is also important to ensure appropriate dosage adjustments are made for concomitant medications according to age, e.g., enoxaparin, weight, e.g., prasugrel, and renal function, e.g., enoxaparin and fondaparinux. The next question reads, the physician wishes to write a prescription for a beta blocker. What are the benefits of administering a beta blocker to PhD? Should it be given as IV therapy or started as oral therapy a few days after the infarction? Beta blockers offer significant benefits to the myocardial infarction patient. Several large trials gave IV beta blockers up to 24 hours after symptom onset, followed by oral therapy. Other studies used oral therapy alone beginning days after the infarction. Early IV administration appears to be most beneficial, with a reduction in mortality of about 25% in the first 2 days when the results of these trials are pooled. However, late oral therapy alone, initiated up to 21 days after an myocardial infarction in the beta blocker in heart attack trial, was also associated with a substantial reduction in mortality, around 10%. Early IV administration of propranolol, metoprolol, timolol, and atenolol has been studied. Typically, metoprolol is used in the acute setting because of its beta-1 selectivity, ease of dosing and administration, and weight of evidence. Oral carvedilol, a non-selective beta and alpha blocker, has been used in the peri-infarction period, specifically in patients with left ventricular dysfunction. In the carvedilol post-infarction survival control in left ventricular dysfunction, abbreviated as Capricorn trial, carvedilol 6.25 mg twice daily titrated to 25 mg twice daily reduced all-cause and cardiovascular mortality as well as recurrent non-fatal myocardial infarction. It is important to tailor beta blockade therapy for each patient, as evidenced in the COMMIT trial. In this study, patients were randomized to placebo or metoprolol, up to 15 mg IV of metoprolol, then oral 200 mg metoprolol succinate daily, within 24 hours of acute myocardial infarction. Although metoprolol reduced reinfarction and ventricular fibrillation rates compared with placebo, it was associated with a significant increase in cardiogenic shock. Patients with hemodynamic instability at randomization were at greatest risk of early cardiogenic shock associated with metoprolol. Given these concerns, oral beta blockers are generally preferred. If the patient is hypertensive or having ongoing ischemia, then IV metoprolol tartrate, 5 mg IV every 5 minutes as tolerated up to 3 doses, can be considered. For all other patients without contraindications, oral metoprolol tartrate 25 to 50 mg every 6 to 12 hours should be initiated. Doses should be titrated on the basis of BP and heart rate. If a patient has transient cardiac decompensation or is at risk for cardiogenic shock during the acute infarction period, early IV beta blockers should be withheld. The patient's condition may be observed for a few days. If it stabilizes, oral therapy is initiated and titrated slowly. The ACC/AHA guidelines highlight the importance of an individualized approach, but do provide guidance on suggested dosing recommendations for both acute and long-term use. In our case, PhD's situation is complicated by his history of intermittent pulmonary problems. In deciding whether to attempt use of beta blockers in patients with pulmonary disease, one must determine the nature of the pulmonary problem, i.e., reactive airway disease. It also would be helpful to determine PhD's need for routine use of beta agonists to help quantify the severity of his disease. By history, PhD does not use beta agonist bronchodilators routinely. No history is given regarding his pulmonary function tests or the degree of reversibility of his airway disease with bronchodilators. Beta-1 selective antagonists are the drugs of choice in these patients, but at higher doses, e.g., metoprolol doses more than 100 mg per day, the relative beta-1 selectivity may be lost. A patient would need to experience significant worsening of the pulmonary disease to justify avoiding beta blockers. A better history of PhD's pulmonary problems should be obtained. If they are minor and as he has experienced an uncomplicated myocardial infarction, PhD may be a candidate for early therapy with metoprolol to reduce chest pain as well as decrease the risk of reinfarction and arrhythmias. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 301.